A very good afternoon to all of you, and a warm welcome to Professor D.K. Arvind, a professor in University of Edinburgh. Uh, Welcome to the 53rd Air Quality Management lecture. So, I'll give you some brief overview of Air Quality Management lecture series. We started this lecture 4 years back in October 2020, and the idea is to make sure that more and more people interested to work and understand the various challenges, not only a country like us, many other countries facing with air pollution, and provide some solutions both locally and globally. It will also provide some platform for exchanging the knowledge and also some networking and various opportunity to explore. So this gives some glimpse of the various speakers who were part of this air quality management lecture series in the earlier. And this is about continuing with that. You must be noticing there are 52 photos. So each were different, and the next photo is waiting to come with Dr. Arvind. Just to give some more details about this lecture series, and as we started working in this area and networking and collaborating with various institutions, we also felt that there is a platform to engage the community. So in that connection, we started Air Quality Management Association in July 2022, and our director inaugurated this society. And it's a registered society, and basically to look at engaging people works in various domains of the air quality management, medical professionals, schools, college students, scientists, engineers, faculties, regulatory agencies, NGOs, industries. So we were trying to make sure that there are roughly now we have about 60 members, and we are keep expanding that. Then I also would like to say most of our collaborations expanded with funding from UKRE with the CEPHA network, the Clean Environment Planetary Health in Asia. And one of the idea is this is a large network project. Colleagues from different countries worked. And we were trying to look at the engaging in the research, various activities that required, and more importantly, what works, identify what works, and strengthen international cooperations, building capacity, and of course, once if you're networking it, you can also explore some possibilities, opportunities for the research cooperations. And more details are available with the CEPHA network. And we have successfully completed 9 years annual Indian International Conference on Air Quality Management. So we were, hosting this year 10th. Probably we were exploring to host it in Abu Dhabi. So we will see. More details will be available. So now I request Lakshmi to introduce Professor D.K. Arvind. Welcome you all to the Air Quality Management Lecture Series.
Dr. D.K. Arvind is a full professor in School of Informatics, University of Edinburgh, where he holds a personal chair in distributed wireless computation, and is a CITRIS visiting professor at University of California at Berkeley, USA. He was previously for 4 years a research scientist at the School of Computer Science, Carnegie Mellon University, USA. He is the director of Center for Speckled Computing and has been the principal investigator on projects funded by the UK Engineering and Physical Sciences Research Council, Medical Research Council, Natural Environment Research Council, Arts and Humanities Research Council, Scottish Funding Council, EU Framework 7, Scottish Enterprise, US Office of Naval Research, US Air Force Research Laboratory, and by several leading technology companies. His research interests center around sensor data analytics using machine learning targeted at environmental and healthcare applications. Today's talk is titled Machine Learning and Causal Analysis of Wearable-Derived Datasets from Patients with Chronic Airways Diseases and Short-Term Impact of Air Pollution. The talk will explore the use of miniature wearable sensors and machine learning to analyze the short-term health effects of air pollution, focusing on vulnerable urban populations. It is divided into three parts: wearable sensors and data collection, machine learning analysis, and clinical trials. The talk is relevant for researchers in machine learning, wearable devices, and air quality monitoring. We welcome you, sir.
Right. While that's being set up, thank you very much for your kind invitation. Thank you very much to Professor Shiva Nagendra, who organized this at very short notice. And we've had a long association, the two of us. In fact, the early prototype for this one, which was the size of a large box, it's called the AirSpec now. We first tested it out with Shiva Nagendra in his lab in IIT Madras about 10 years ago. So thank you very much for the long association. The title of the talk is kind of in the intersection of air quality and its health effects. So you can do research in long-term health effects of air quality, longitudinal studies over many years. That's not my interest in this work anyway, in the talk. It's the short-term effects. When you say short-term effects, we mean effects which last, say, anywhere from 1 hour to 8 hours, or up to 48 hours, okay? When you see wearable devices, these are the kinds of wearable devices I'm going to talk about. So this is the AirSpec device, the personal version of this, which can be clipped onto the belt. And that measures every 30 seconds PM10, PM2.5, PM1, and size fractions in 16 bins, ranging from 0.38 microns to 16 microns. And so that, you might say, is the cause, right? And the effect is really measured using this sensor, which is called the RESPEC, and that's worn as a plaster on the chest. And that measures a number of physiological parameters targeted at people with chronic airways diseases. And the kinds of chronic airways diseases that we work with is people with asthma, both pediatrics in the sense that they are young, below the ages of 18, adult asthma, and also what's called COPD, which is an umbrella term for, it's a chronic disease, which is an umbrella term for emphysema, chronic bronchitis, upper airways obstruction, okay, who are very sensitive to air pollution. So I've just situated the talk, what's the area we're going to look at. So we will talk about the RESPEC, AirSpec, these devices. We'll also talk about some machine learning based analysis of spatiotemporal prediction of PM2.5 exposure. And also some recent work on using the particle size distribution in order to identify different sources of air pollution. It turns out, we've discovered that different sources have their own unique signature in terms of the particle size distribution, and that can be exploited using machine learning. And that's very recent work. The ML-based analysis of the RESPEC data, this data here, in order to identify static dynamic physical activity, cough episodes, and also the regularity of the breath, And then if people can wear these devices on their own, and there are lots of medical applications where we want to monitor remotely patients with these conditions. But you can also, and you can use this individually if you want to look at air exposure studies. But you can also use them in combination. You can use both sensors, so you get 2 time series data, which are synchronized. And each data is time-stamped and location-stamped, GPS stamped. So you can use that information in order to look for causal analysis, not just plain association, which is a weaker condition, but a much more stricter condition where event in time series A causes an event in time series B within a certain time lag. You can see the time lag could be anywhere between 48 hours or 8 hours or 1 hour, depending on what you're interested in. Okay, so that encapsulates the what we're going to talk about. And there are some case studies from clinical trials. And these sensors are used in countries in 4 continents around the world. So there'll be trials from different parts of the world. I don't know what I chose. I can't remember it now, but you'll see that. Okay, so acknowledgements to all our funding agencies. And these are all the PhD students and masters and undergraduate students who worked on this. So thank you to all of them. A number of clinical partners around the world that we work with. And these are different projects where we're looking at, there's projects on long COVID, for instance, people who suffered lung insults during COVID, were hospitalized, they've come out, and the conditions have persisted. So things like breathlessness, how do you monitor that? What causes breathlessness? Are there certain events after a certain time lag causes their breathlessness? Can they avoid those events? And things of that sort. These are the different data sets that we have. We collect data from different parts of the world, and we do all the analytics and make all the results available. So IIT Madras could be up here at a later stage, hopefully. And there are lots of papers, so I'm going to So let's talk about the sensor data collection environment for clinical trials in health effects of air pollution. The idea here was normally these trials tend to be very time-consuming, labor-intensive, because you're doing everything manually. The idea here was, can we do the studies in such a way using these 3 kinds of sensors? So that's the AirSpec sensor, an earlier version of that. And then this is the ResSpec, which measures the physiological. And this is a stationary AirSpec stationary, which is powered off solar cells, and that can be attached to street furniture, for instance. And that collects data every 5 minutes, and it uploads the data to the server via the cellular network. And it also has nitrogen dioxide and ozone sensors in them. And it measures PM10, PM2.5, PM1, and all the various size fractions as well. And again, that is time-stamped and location-stamped and uploaded to the server. And that's what happens here, because you have an entire backend here where the data is uploaded. In this case, both of these communicate via Bluetooth to a mobile phone app. And from there, it's uploaded to the server, either via the Wi-Fi, or if you have a SIM card in there, then it goes in real time. And it goes to the server where we run all the methods, the machine learning methods, and you can view the results via a dashboard, okay, which is, all the data is anonymized as well. And in the dashboard, you can actually see in real time the person moving around and see what the exposure levels are. So there's a map as well as time series data, and these two are synchronized. So you can click on this and see where the person is. You can click on that and see what the levels are, okay? And this gives you the bin counts, the 16 bins. So everything is automated, right from collecting the data to uploading the data to actually running the methods, the machine learning methods in the back end, and making this available to the end user in this case, depending who the end user is. They can actually see the data in different forms. And all this was implemented in Edinburgh, including these various sensors as well. So we're vertically integrated. We go all the way from sensor technology to machine learning. Okay. And you can see all the data is spatially resolved. If the person is moving around in the space, This is around Imperial College in London, and the person is cycling through London there. You can also, so this is somewhere in Delhi, I think, yes. Yeah, looks like it. And you can basically track the people. And this is very useful, especially when you're doing clinical trials, because you want to know whether this person is actually wearing it and whether the person is collecting data. So it's a way in which to also check on conformance and actually get in touch with them if they're having any issues. The RESPEC itself is lightweight. It has 17 grams, including a battery, so it can be worn as a plaster on the chest. It has a battery lifetime of 6 months. We're very proud of that. And it's unobtrusive, it's small. It's always on. There are no buttons, either to start it or to transfer data, because people forget to do those things, so it needs to be always on and still run for 6 months. And the data is forwarded automatically via Bluetooth LE to an Android app, and you can wirelessly recharge the batteries on the RESPEC every 6 months. You just leave it for about 4 hours or so, and it recharges for the next 6 months. So hopefully what we should see should be an animation of the RESPEC. Yeah, it works. So that's real movement of the chest wall. And these are the 3-axis accelerometers. And then you derive the breathing flow. Okay, there's a breathing flow. You inhale and you exhale. And then from that, you can count the number of breaths every minute. So it is reported as breaths per minute. That's how respiratory rate is reported. So here's an example of data coming from the RESPEC. You can also use the raw accelerometer data to apply various analytics, machine learning-based analytics to, for instance, extract what activity they're performing every minute. So this, what you see here is 24 hours worth of data, where each line here has 60 pixels corresponding to the minute of the hour. And there are 24 such lines corresponding to 24 hours in a day. So that is 24 hours worth of data that you find here at minute level resolution. And in this case, there are 3 different activities that's been resolved. One is lying down. The other one is stationary, which is in blue, and activity is in red. So that's what you see here. And what you see on this side is really the intensity of the activity they're indulging in. And that is measured usually in terms of the equivalent VO2 measure, volume of oxygen consumed when performing an activity. And when doing that, you usually have a face mask and then you have a box of electronics that it goes to. But in this case, we have calibrated our sensors to give us the equivalent VO2 measure. So you can see here when the person is lying down, the activity is very low compared to other activities. And then this is the respiratory rate in breaths per minute. And it measures quiet breathing at rest, because that's how respiratory or pulmonologists usually measure the breathing rate. And you can see when there is high activity corresponding to that, it cuts out. It doesn't give you the breathing rate because it only gives you quiet breathing at rest. And you can do analytics, meta-analytic sort of analysis on this data. Person is lying down, very low activity, low breathing rate, and we know that when a person is sleeping, the breathing rate depresses, it actually comes down. So you can conclude that perhaps this person is sleeping, except somewhere here. The breathing rate is very high. But the person is inactive, it's 0 almost. And the person is still lying down. The person is not active. So the breathing rate is racing as if the person is running or climbing stairs. So we can only hypothesize that the person is having a bad dream, having a nightmare. The breathing rate is racing, but they're still lying down really stiff and unable to move. So that's just a conjecture. But there's a lot of information that you can get out of this. The other very interesting thing is the particle size distribution that I talked about before. in 16 bins that you get. And there's an example of the bin sizes. And this is the histogram. It gives you the number of particles of different sizes in these bins. So the first one I'd like to talk about is the measurement of personal exposure to secondhand smoking using particle size distribution. Now, what I said earlier is that different sources have their own unique signature in terms of particle size distribution. So this is a box plot of the particle size distributions, the number of particles ranging from bin 0 to bin 15, okay? This is 0.38 to 0.42 microns, and that is 16 plus microns. Now, they're slightly misleading because of the scale, you're not seeing the ones on the smaller ones, but you can see something there. So each one seems to have a unique signature, which is extremely useful. So the way you gather this data is to have the AirSpec device sitting next to the source, in this case, the background, or you're boiling some water in this case, or it's a mosquito coil. So we're trying to differentiate between common sources indoors and outdoors. So some of them are indoors, so such as deep frying. It could be either indoors or it could be outdoors if you have street food or something like that. Or this is just frying, and that's incense, and you're burning incense, mainly indoors. Secondhand smoking, that's what it looks like. Spraying of deodorants, of things like indoor air, what do you call it? Whatever the name is, air scent giver, let's call it that. Spraying, and then this is traffic, sort of the exhaust from vehicles. Okay, and this is an example of a machine learning, the results, the accuracy of a machine learning method, which has been trained, and you can see on the bottom, you can see you collect these samples at 30-second resolution, and then you mix them up in different proportions, where it's 10% is smoking, and the other 90% is other sources, okay? Or 20% smoking, 30% smoking, 40% smoking, and so on and so forth. So you can create a data set with different combinations of secondhand smoking along with other sources. Some of them could be confounders as well, okay? And then you train a network in order to be able to recognize whether in that 30-second secondhand smoking is a dominant source, because that's what we're interested in. And although it dips down as low as that when it's 50-50, which is understandable, but when it's a dominant source, which is usually dominant is above 50%, we find that the accuracy is very close to, above 85 for 50% and above 90 from 60% up. So it works for us, although the accuracy does drop on 50-50, and we can actually work on that, improve that. As far as we're concerned, this is good enough for us to be able to identify at 30-second resolution what is the dominant source, and whether secondhand smoking is the dominant source in this case. You can have other dominant sources as well. We can train the network to do that. So this is extremely useful in public health research, where you want to know what is the exposure to secondhand smoking if asthmatic children, for instance, so that you can give them advice on what to do and what not to do, okay? They might not be smokers themselves, but they would be exposed to secondhand smoking. Or pregnant mothers, for instance, we don't want them to be exposed to secondhand smoking. So although they don't smoke themselves, they might be in the environment, so you can give them some advice on secondhand smoking, and also look at the health effects of that if those are clinical trials. So this is extremely useful application of machine learning methods using the particle size distribution of the data that you get from these devices. Right. I'm going to talk a little bit about spatiotemporal prediction of PM 2.5 exposure using a network of stationary airspecs that you saw previously, and also the AirSpec P monitor. Now, in the interest of time, I know that I need to go a bit faster now. I'm just going to tell you what the principle is. So the idea here is that people in this case, these are asthmatics, adult asthmatics in London. They're wearing these sensors for a period of 14 days, and also the AirSpec sensor. And they're moving around the space that you see here, and they have different exposure levels. Okay, that's great. So we treat that as ground truth, because every 30 seconds you have the GPS location and the timestamp and the PM 2.5 values. Okay, and you treat that as the ground truth. The challenge is, can we predict what those ground truths are if you have data from a network of air quality monitoring stations, both the AirSpec stationary, which gives you data every 5 minutes, that's the time resolution that you have there, or from the air quality monitoring stations that is available. These are the local authorities have air quality monitoring stations, but they only provide data every hour, so it doesn't give you the same resolution as we wanted, but that's okay. So that's the challenge. So you are spatio-temporally predicting what those values are based on a network of stationary air quality monitoring stations. And you can use different machine learning methods here, so that what you try and do is you predict a certain value, and then you know what the actual value is, at least when you are developing the machine learning models. You know the actual value, the delta, and you retrain them so that you reduce the delta as much as possible. Okay? So that's an example of how you can use spatiotemporal modeling using the personal exposure levels as ground truth in order to develop methods which can predict. And these are dynamic methods in the sense that along with the PM 2.5 levels, you also have things like the land use information, OpenStreetMap information on the traffic, and also things like you can use the weather data, such as the wind speed and wind direction as well. So there's lots of other data. And this is in contrast to the very heavy models that people have, where you have chemical models and dynamic models as to how these chemicals move in order to predict air quality in different parts. Okay, so that's the other approach. And what I want to highlight here is that I'm comparing data collected in London, which is up here, with the data collected in Delhi, right? And this is for hour of the day. And just look at the contrast between the levels here. I thought I might just point that out to you. And then these are from January to that time of the year, by the month, as to how the temperature and the air quality varies. And this is for different seasons in London and Delhi. And these are the various features which are exploited in the machine learning models that you see here. And these were the various machine learning models that we looked at, and these were the results for Inhale and for Daphne. You know, these are the two projects which use these. Still not as good as we would like it to, but at least we're moving in the right direction. And the way we can, and this also shows you the delta between what was predicted and what is the actual value. You can actually see that. So that's the difference on that scale that you can actually see there. It's pretty good, but there are some places, like when you are in a green space like that, or when you're indoors, the prediction actually, the error is much greater. And the next version of this model is actually using the same data to find out whether you're indoors or outdoors, and using that as a feature. And also if you're in a green space, and you can get that from the land use data from the OpenStreetMap OSM, and you can exploit that to actually do this. So these are some of the features that we're doing in future work. How many minutes do I have? Okay, all right. So that is, in a sense, the measurements of PM 2.5, the prediction of PM 2.5. You might say that is the exposure. Okay, so that's the left-hand side of the equation, as it were. Now we want to look at the right-hand side of the equation. So what is the effect? And we want to measure the effect automatically in this case without having to bring them to the hospital. You want to be able to measure this continuously. And respiratory rate quite often could be a good proxy for lung function. Okay, so that's the hypothesis here, and that's what we're going to use going forward. So I think so this is the actual data collection environment. You have the user's wearing the RESPEC. They have an Android phone, an app in there. It collects data, uploads it to the cloud. You do the analytics. You make it available on the dashboard. And each patient has their own unique identifier, so there's no personal information there. And then you have the clinician, either a nurse or whoever, looks at the data, and we analyze the data and present the form, which is actionable information, quite often in a traffic light system. So we can analyze the raw accelerometer data from the RESPEC to classify at 1 minute resolution whether they're performing a physical activity in that minute, sitting, standing, lying down in one of 4 orientations, they're supine or they're prone, facing left, facing right. That is, supine is lying on the back, prone is lying on their stomach. Dynamic physical activities such as walking, shuffle walking, running, climbing up and down stairs. Shuffle walking is especially important because you're walking, especially older people like conditions with COPD and asthma. They don't raise their feet, but they actually move forward, but shuffling with their feet touching the ground, and there is not much raise. So it is quite challenging to actually detect shuffle walking. Cough episodes is very important. Cough is a very important indicator of deteriorating conditions in asthma and COPD patients. So you can measure coughs at 1 minute resolution, and we can actually we do that at 2 second resolution. But over a minute, we can, if the dominant minutes are due to coughs, then we classify that minute was a cough minute. Okay. You can also come up with sleep-wake episodes where the person is sleeping in that minute or awake. I'm not going to talk about that much, but that's very useful. And also, we can actually do the analysis not at a minute level, as we do for respiratory rate, but you can do it at the individual breath level. You can look at the shape of the breath and see whether it's a normal breath, or is it a shallow breath, or is it a shallow rapid breath? Because these are indicators of whether the patient's condition is worsening. And if it's an asthma or a COPD, then it could be that it is worsening because they have been exposed to a higher dose of air pollution sometime in the near past. Okay, if that's the case, then we need to be able to come up with sound analytical methods which can draw a causal link from that exposure to changes in the breathing rate or changes in their breath level. So that's how I'm connecting at the analytical level using causal analysis data which is collected by one sensor at 1 minute resolution and data collected by another sensor at 1 minute resolution. One measures the cause, in this case, PM, or it could be humidity, or it could be temperature, because we know that these patients are affected by those environmental factors as well. And the effect, in this case, is changes in your respiratory rate, changes in the number of coughs, or even changes in the shape of your breath. Okay, that's astounding, really, if you can do all that. And we can, as it turns out. So the raw accelerometer data looks something like this. If you're breathing, it looks like that. If you're talking, it looks like that. If you're hyperventilating, it looks like that. If you're coughing, it looks like that. So the challenge for us is to be able to classify that in the presence of other confounders, right, as well as other noise that you have, etc. So we have a classification pipeline, which first classifies what type of activity you are involved in. And the activity is important because in the case of coughs, identifying coughs is a difficult problem. So you need to break it down and say, okay, first let me identify coughs when the patient is stationary, and we can detect when the patient is stationary using machine learning methods. And then when the person is active, we will not identify coughs in those places, okay? So you have to make certain assumptions here, and that is the assumption that we make. And this is the dashboard view and thing. So different types of activities. So that's how the results come out. These are asthmatic patients, and you can see over the period that you collected data over the 2 weeks, what proportion of time do they spend in different activities. And that's useful because if the dynamic activities changes over time at different times of the day, then you might want to be concerned about. So you can then do another level of analysis on the data. And these are the different social signals over time. So for instance, if the number of cough increases, then you can act on that as well. So what I'm going to show you is something I haven't talked about. It's the same device, worn as a plaster on the chest, the respect, can also give you independently step counts, okay? You can also get step count, you can also get steps or walking from the activity classification. So there are two independent algorithms which gives you this. And this is important because the way we calculate the accuracy of these classification is that you're using labeled data. So you have a set of labeled data, and then based on the labeled data, you can see how accurate your classification method is. But when you're using it in the field, you're using it in the wild, you don't have any labeled data there, okay? So this is unseen data. And basically you are hoping that the results that you get would be just as accurate with a certain amount of attenuation in the accuracy that you're getting. But another way of checking is to have two independent algorithms and seeing whether one corroborates the other. So in this case, what you're seeing here is these are all the walking activity from one classification using machine learning, and using a completely different method, which is based on frequency. You can see the cumulative step count. And you can see that there's a jump in the step count each time there is sort of these yellows, which are the walking activities that you find. You know, there's not much here that goes up there. So in this way, in the wild, we can actually corroborate and validate that these people are doing the right thing, okay? You can also have things like cameras and all that looking at them, but you know, that's an invasion of privacy. It's not always easy to do. And the last thing you want to do is ask people to keep diaries because it's very noisy and people don't do it, okay? So there are other cough classification methods that I'm going to talk to you about. So this is one method. I'm going to show you another method which is based on what's called symmetric projection attractor reconstruction. This is my PhD student, Basara. And what you do here is really you are mapping from the temporal space to the frequency space, in this case, the phase space of a dynamic system from the time series data. And then you do these attractor reconstructions, and then you basically remove any baseline variations where there is a certain DC signal, equivalent of a DC signal, which is in there. Okay, and then you have to select the appropriate time delay and embedding dimensions there. And this is what it looks like when you're moving from one domain to another domain. And what you really want to see is how SPAR really improves what is essentially a very difficult problem. It is with your device placed on the chest where you measure the respiratory rate, you're trying to measure cough as well. The competitor method is using something like a microphone, right, which is attached to your chest, and then you use the data from the microphone to detect coughs. You can use machine learning methods or manual counting, but you're competing against that. But the microphone won't last 6 months. You know, it's very power hungry for a start. Whereas you get all the other data as well, along with breathing rate, breathing flow, and coughs, okay? So this shows you improvements over the traditional baseline methods by using these kinds of pre-processing and then using deep learning methods along with this. Okay, right. And I talked to you earlier about how you can validate this in the field. Another way of validating something like this in the field is to see, has there been observational data collected by someone else? In this case, it's coughs and how coughs vary with the time of the day. Okay, there's a lot of studies where people have observed manually intensive over many months, patients, watching them, what they're doing, counting the number of coughs and doing it that way. And in this case, we are able to reproduce the same shape, that is very low coughs at night when they're sleeping, and just as they're waking up, the number of coughs increase and it goes up and then comes down again. Okay, so, and we are reproducing the same pattern over the day. And this is based on 904 days worth of unseen data, okay, from COPD patients. And this is known to be in COPD patients, matches observational studies. So that's another way in which to validate in the field. So you have to set yourself very strict kind of conditions, how good your method is. First of all, using label data and seeing that you get high accuracy, and then putting it in the field and seeing whether it conforms with observational data that you see elsewhere. Okay, I'm going to go very rapidly to this to say that if you want to look at the shape of the breath, then what you use is things like the area under the curve here. That's a typical breath there. So you're taking a sequence that is a breathing sequence, the breathing signal, and then you break that up into individual breaths. That is the expiration, inspiration, inhale, exhale, that kind of activity. And you take individual breaths and then you analyze the shape of the breath and how quickly they're breathing. There's something called as rapid shallow breathing, which is of great interest to people. Okay, what I'm going to do next is to really go to something I want to talk about, which was very topical in Delhi, where we monitored patients, asthma patients, young asthmatics with the ages of 10 and 18, as part of air pollution, human health, a large UK-India study in which Professor Nagendra was also part in a different study in there. And what you want to be able to do here is see, is there a causal link? Sensors are collected by the personal PM monitor that you talked about before, and also using the RESPECT data, so wearing both of them over a 48-hour period. And then we came up with novel analytical methods to extract causal relationship from PM 2.5 to respiratory rate for different time lags, okay? And then we came up with a sensitivity index for that. And then we had to, and after the 48 hours, they came to the hospital and you do the gold standard pulmonary function test using a spirometer. So you do the spirometer test, the lung function tests are taken after this. And then you want to be able to see whether the sensitivity index can predict the lung function tests. Okay, so you get a certain ordering with the in terms of their sensitivity using this kind of number of causal links. That is one thing, me saying that is a good indicator of their sensitivity to the air pollution. And it's quite another convincing a pulmonary physician that is indeed the case because they have their own standard test. So in other words, a new parameter, something like sensitivity to air pollution, based on the number of causal links, needs to be validated against the gold standards which currently exist or has been existing for the past 120 years. Okay, that's how you challenge yourself and see how good your methods are compared to the gold standards. So the breakthrough result here is the respiratory rate can serve as a proxy for lung function to stratify asthmatic sensitivity to air particulate matter and quantify the strength of the exposure-response relationship, okay? So the method itself, the way it works is that you have causal discovery. That's a method where you have a causal model, which is a probability model, and a causal structure. And then this causal structure is learned by the causal discovery algorithm. And then we apply the causal discovery algorithm, learn the relationship between respiratory rate, activity level, PM2.5, temperature and humidity for all subjects in the asthmatic cohort. Why do you take all of these? Although we are only interested in PM2.5 to respiratory rate, but these are confounders, because if you have high activity level, and we measure activity using the RESPEC, then your respiratory rate will naturally go up, because you're running or doing something like that, your respiratory rate will go up. So that's a confounder, so you have to take account of that. And we know that temperature and humidity also affects the respiratory rate. So you have to use that, you have to take account of that as well. And say, in the presence of high activity level, in the presence of temperature, in the presence of humidity, can you isolate the effect of PM2.5 on respiratory rate? So effectively, that's what you're doing here. And we can do that. So the way you do it is you come up with like a finite state machine, that's what it's called, and you can look at different effects that you see between activity, PM2.5 activity level. So that's a summary of that. But what we can also do is really break it down at the minute level as to which time delay they actually are sensitive to the PM2.5. And the way we do this is we calculate what is the p-value of the direct causal links from PM2.5 to respiratory. In this case, it's every 15 minutes, okay? So I've just kind of given you a summary of that. And there are 5 patients there. The greens are the ones which have a causal link with a p-value less than 0.05. The oranges are the ones where we have a causal link, but it's between 0.05 and 0.1. And the red ones are 0.1 and above. In other words, what you have at the bottom 2 are highly sensitive because they have causal links which are statistically significant. The middle one is moderately sensitive, and the top 2 are not sensitive, okay? So this is the principle that you use. You count the number of causal links. It also tells you the time delay over 15 minutes where the causal link is. Now, we can actually do much better than that by looking at the causal links over a period of 60 minutes time delay. And these are all the patients here who have been ordered in terms of the number of causal links. Low causal links at the top, moderate causal links at the middle, and large number of causal links at the bottom. So, and that, we reckon, would be the sensitivity index, the number of causal links, at least one kind of sensitivity index. We have come up with others as well, but I'm just going to stick to one. Okay, so this is the ordering. The challenge now is to be able to demonstrate that this ordering can actually predict the lung function that is collected 48 hours after which this data was collected in the hospital by the clinicians, and they trust the lung function. Okay, this is a new method. How do they know that what I'm saying is correct? So the onus is on us to be able to predict that in a significant way. So these are the lung functions. It's less important that you know what the lung functions are. Just to indicate that in the next table that you're going to see a lung function, and you're going to see a value called IQR, which is interpreted, in this case it's 28, and then there's a percentage change there, which is minus 8.83, with a 95% confidence interval. And the way you would interpret this is, given 2 subjects who differ in their respective lung function test there by 28, okay, in this case, higher the value, the better is their lung function, lower the value, worse is their lung function. Therefore, the subject with a higher value will have 8.83% fewer causal links. Fewer causal links means they're less sensitive. So if they have a higher lung function test in this case, then they should have fewer causal links. Okay, that's how you interpret this. And what this tells us, the other thing that you need to know, in this case, p-value is nice and low, and the significance of the change means that it's too two of these, that is p-value is less than 0.01, and the 3 stars is less than 0.001. That is, it is highly, highly significant, okay? And this is an example of different features, okay? And we can have the percentage changes that you have there, and also the IQR. And look at the significance of change, very highly significant, okay? So, and this is what actually captures the imagination of the clinicians, because now they can see that what you're doing actually predicts the method that we've been using for 120 years, okay? And the net result of this is, yes, let's continue the study. So Daphne has continued into its next phase, where we took 10 subjects highly sensitive, 10 subjects moderately sensitive, and 10 subjects least sensitive, and then followed them for 12 months. Okay, followed them for a full 12 months so that we have comprehensive data, and every 3 months they come to the hospital, and before that they wear the devices, collect data, you do the lung function test and also exercise tests and various other tests. And the idea here is to relate the two as we did previously in Daphne 1.0. Okay, now I'm going to conclude in a few minutes by saying that you can do the same thing from, say, particle sizes. Are you more sensitive to small sizes or larger sizes? And how does that impact, in this case, your coughs? So there are some people who are sensitive to pollen, for instance, large sizes, and they develop certain allergies and things of that sort. So you can actually account for that as well. We also looked at, in Uganda, with Harvard Medical School, we looked at things like, what is the effect of indoor air pollution on the recovery of patients who were discharged with COVID-19, right? After they've been admitted with COVID-19, they recovered from COVID, but they had lung insults, okay? How does indoor air pollution, in this case they use solid fuel for cooking in Kampala, in Uganda, how does that affect the recovery? Okay, so that's what we're looking at here. And I'm just going to very quickly show you that over the period how using the respiratory rate, so these are 3 types of patients. They had severe lung insults, moderate, and then mild. And you can see the respiratory rate from between 23, almost 24 breaths per minute recovers down to less than 19 breaths per minute. So you can see that the respiratory rate is a good proxy for lung function tests. You know, you don't have to go to the hospital and do the pulmonary function test anymore. You can use this device for that. And there's something called the 6-minute walk test, where they're asked to walk for 6 minutes on a straight line, on a level surface. And what we can see, and you calculate the breathing rate before the 6-minute walk test and the breathing rate after a 6-minute walk test. And you can see the severe ones have the breathing rate is much higher after the 6-minute walk test. And generally, even before that, it's much higher than the moderate to the mild group. So they exhibited the largest increase in respiratory rate and the highest respiratory rate after the 6-minute walk test, which also gives you a condition of their lungs as well. It's often used in this. So we can use this. Bishkek is in Kyrgyz Republic. They've been using these sensors in patients who have been admitted to the hospital with COPD exacerbation, and they're recovering at home. And we can actually see the respiratory rate really going down over time. That is recovery, that's good. And you can also see that the breath regularity goes up. So they have less instances of rapid shallow breathing. So this can be used to monitor patients at home as well. And they also have a score that they have called the CAT score in this case, or the ACT score. As they improve, the ACT score goes up, which is good. That means they're recovering. And this is a self-administered questionnaire that the patients have. So what you're doing here is you're triangulating between the patient's own perception of how their condition is improving based on standardized questionnaires and what the sensor is telling us. Basically, the sensor is telling us the same. So it's a way of validating the sensor as well. Conclusions. The air-respec ecosystem has been deployed in projects in countries in 4 continents in remote health monitoring and health effect studies, mainly due to air pollution. And then this ML-based analysis of respec and airspec data, which takes place in the cloud. And then causal analysis to satisfy asthma patients based on the sensitivity to airborne particles that you saw in Delhi. And future work, one of the things that we are really interested in, and this we are open to collaboration on this, is we've been talking about the concentrations. PM 2.5 gives you concentrations. It doesn't say anything about the composition. And we have a way in which we can identify the source based on their particle size distribution. But you can also find a way in which to find out what are the pollutants in that source. And we can come up with a toxicity index for each of those pollutants. So you might have a case where they might have very high PM 2.5, very high concentration, but the composition could be very benign. Whereas it might have a low concentration, PM 2.5 value, but the composition could be more toxic, in which case there are 2 sides of the same coin, right? So you need to understand both, and that's what we are looking at. Thank you very much. Thank you.
Thank you, Arvind, for a wonderful talk. Any questions? Any questions? Any clarifications?
Yes.
Few questions. There was one graph in the very initial of the presentation which showed accuracy versus second line smoking.
Yes.
What does that accuracy indicate? Accuracy of what?
So it's accuracy of predicting correctly that it's a secondhand smoking in that 30 seconds that we are collecting the data. So let me explain how we do this. So you create a data set based on real bin values for that particular source, okay? So you have snippets of these, right? And then you make up an entire data set where the proportion of the secondhand smoking consists of 20% of all the data that you have in there. The rest of the 80% is other sources. And then it's like Monte Carlo, that you go 10%, 20%, 30%, 40%, and go on and so forth. And then you train your model in order to, so 70% of that you use for training the model, and the other 10% you validate it, and the 20% is unseen data that you test it on. And it's that 20% unseen data that you present to it. Does it correctly identify which ones are the smoking 30-second time slices, right? And that's how you measure for different concentrations of smoking in that secondhand smoking in that particular data set.
And the x-axis was percentage second-hand smoking. What does that mean?
That means precisely in that data set, I have 10% is secondhand smoking, 90% is rest. And then I have 20% secondhand smoking, 80% rest. And the rest itself, you can have different combinations because there are lots of different sources. Okay. Then the problem arises is how does one, so these are labeled data to start with, because you need to start with labeled data, right? And what you see in the y-axis is the accuracy.
And the second question is about, you mentioned that approach using this ad bulky monitoring systems that you have, and then you can predict how the, basically some top-down approach, I think, that you're trying to predict exposure of different,
Yes,
different parts.
that's right.
And you told that for sensitive or it showed higher deviations in areas with green spaces or.
That's right. Yes.
So does it show higher deviation also in places with more pollution, like
No, it does well, but there's no pollution because we haven't accounted for green spaces. Because we know that in that space, if you have green spaces, the pollution tends to be lower, right? Green spaces generally have lower levels of pollution compared to, say, places where there are roads and places where people live and various other things. So it doesn't account for that. So if you were to account for that this area is a green space, then you could improve the air quality prediction. That's number one. And number two, it's also the case that it doesn't differentiate between indoors and outdoors. If you can find out at any time, you can use those as features, whether they are indoors or outdoors, and that can be done automatically. And that's the improvements that we are making to the system. So the way it works is that you have stationary monitors giving you data every 5 minutes on that space, and then you have people moving around in the space wearing these devices. That's the ground truth. So for a given timestamp, for a given GPS location, you have a PM2.5 value. Can you predict those PM2.5 values based on the stationary sensors? Okay. So you have label data to start with, you train that, and then you see whether you can predict that with unseen label data to start with, and then you set it out, and then you're able to. Ideally, what we'd like to do is person wants to go from place A to place B, child goes to school, there's a route that they take from place A to place B. Can you plan the cleanest, shortest route for them to take based on historical data that you have collected from them, say over a 48-hour period or something of that sort? Okay? Right.
One final question.
Mm-hmm.
Why do we use 48 hours? Why only 48 hours?
Okay, so the one in Delhi were school children, young asthmatics, adolescents between the ages of 10 and 18. We felt that 48 hours was the right period that they would actually conform to actually collecting data. In London, for the older asthmatic, they wear it for 2 weeks because they're more likely to stick to instructions and conform. Whereas young children, children of that age are less likely to listen to people say, wear it. There are better things to do than wearing these sensors.
No, I was asking if we could predict it after, we were predicting the behavior after 48 hours, right?
For what?
Based on the activities that they did.
Yes, you can do that. The 48 hours really comes in is the period for which data was collected by the children in Delhi. So if you wanted labeled data, that's the limit up to which we have labeled data for that particular child. Yes. So that's what 48 hours is determined in 48 hours. We can actually do near casting and things like that, go beyond the 48 hours as well. We do that. And also back casting, because patient comes into the hospital, you give them the sensors, and they start wearing it, but you don't know what the exposure was before they came. So you need to back cast as well. So we do back casting and near casting. Right. Yeah, sorry.
So I'm just trying to look at it. This point is just to see that at least you are taking 2 days sample to say that one day and another day there is a getting the comparing of the data from the 24 hours exposure.
Yeah.
Doing all the activities of the
Yes.
child, and then look at it. There are 2 days data are available, so we can even able to explore the possible trends, the kind of exposure that will happen.
Yes. Yeah, 48 hours so that you can get at least, that's another way of looking at it. Collect for 48 hours, you can get at least 24 hours worth of data in this. But it's really the tolerance level that children have is really was the key more than anything else. Okay.
Arvind, there is one question online. why all respirable particles are not taken into account in exposure studies, only 2.5 is taken into consideration. And why average values are not taken into.
So what is the last bit?
Why average values are not taken into account.
Okay, we can do the same things for PM10 and PM1. That's not an issue. We are just demonstrating a principle that you can do this with PM2.5, and most studies do with PM2.5. That's the only reason. We can do the same analysis with PM10. We can do the same analysis with particle size, with bin sizes as well, as we have shown. You can go from bin sizes. You can go from PM10, PM2.5, PM1 as the cause, and the effect is respiratory rate. We can do the same with coughs. Okay. We can do bin size from bin 0 to bin 15 on respiratory rate. We can do the same thing on coughs as well. And we can also do the same for the regularity of the breath. So we can do all the various combinations here. And we're going to start work on sources. Every 30 seconds, if you can identify what's the dominant source in that 30 seconds, then I can go back and do the same analysis on the respiratory rate. There might be some sources have greater causal effects than others. You might not understand the etiology of that as to why it causes it, but at least we'll have the results for that. Okay? So it's a sound method in the sense that you can have different causes and different effects, and then you can have the various combinations between these.
Any other questions?
Yes?
This is regarding the causal algorithm that spoken about. Is it similar to the structural equation modeling that we do? Is both algorithms similar, or how is it different?
I think it's, correct me if I'm wrong, but it's different in the sense that what you do in the case of the causal effect algorithms is that you unfold a causal graph, right, for all the time instances that you have. You unfold a causal graph, and then you look for direct effects and indirect effects from one node in the graph to the other for different time delays, okay? Now, one of the drawbacks of that approach is that it's computationally expensive. As the resolution increases, right, you can do this at 1 minute for delay of 60 minutes, or you can do it at 15 minutes resolution for 8 hours delay, okay, because the computation explodes because your graph actually becomes much larger. And then you look for all these parts within the graph. That's how this method works. It's a brute force approach. People knew about these approaches, but it wasn't feasible. But now that you have lots of computation power, you can actually apply these approaches to these things. So, I mean, that's the strength of the approach. It is in the sense that, and the other thing is, you can actually see what happens at different delays, okay? That's another great strength of the approach, is that you can see, is the time lag, after a short time lag, do you see an effect, or do you see an effect at the end of the time lag? And we see this very clearly over the 8 hours, because we have if you do a cumulative count of all the causal links by the 15-minute delays, okay, over 8 hours, for all the subjects that you saw there, there's some 50-odd subjects, then you see a bump right at the start, lots of causal links, and then it goes down. And then between 7 and 8 hours, you find, 6 and 7 hours, you find another bump going up. And we thought there was a mistake that we were making. There's some error in the work. And when I presented this to the pulmonologist at AIIMS in Delhi, I said, I don't understand this. That's what's happening. 5 hands went up immediately. We know what that is. Early effects is like a shock to the system. Okay, it's a histamine-based effect. Okay, the later effect is a slower effect, is called a lymphocyte-based effect, which are actually controlled by the brain. So it comes from the central nervous system, which controls the breathing. So when there is any inflammation or any kind of external particles of inflammation, it's a slower effect. They said, no, that's not a mistake. We understand, we have seen this. We have observed it. That was a clinching moment when they started believing that there is something in this before they agreed to say, okay, let's do a further study on that. So that's the other advantage of this approach, is that you can resolve down to the minute level for 60 minutes delay with that. These are the advantages compared to the structural approach.
So while evaluating the performance metrics, the decision trees or trees-based model are giving higher performance metrics as compared to the ensemble model, like you see in the random forest or gradient boosting. So what are the causes of that one? And the second question is also, can the number of curves can be linked to the particles concentration in the environment?
It's a number of what?
Curves.
A number of coughs, yeah. How can that be related to the?
Directly linked to the particles concentration.
You can do it both particle concentration, that is PM values.
Yes,
You can do that, as well as what is more interesting, the size of the particles. And I show you one example. We have done both. And I showed you one example in there, a small example of how the sizes of the particles, say very small sizes, does it affect, very large sizes, does it affect. So the effect varies. So we have done that. I just haven't shown you the results. And we are starting to publish these things as well. What is your first question?
The first question is about the performance metrics of the trees-based model versus the ensemble model like MLR. So in one of the slides we have seen the gradient boosting methods for random forest are exhibiting the higher mean absolute percentage error.
Okay.
So what are the reasons for that?
There could be so many different reasons.
That depends on the
It's very context dependent. You have to go into the actual context and see why any of these methods perform better than others. I think.
I just wanted to understand, since we are using this kind of an exposure devices for exposure measurement, and I don't know that the local aerodynamics will influencing what we actually breathe and what these devices collect.
Okay.
So,
Okay, so we wanted to get over the aerodynamics by actually having a pump in there which pulls in air at a very steady rate. Okay, so eddies that you get, local eddies that you get due to movement and things of that sort, or movement around you which might create these eddies, are ironed out by having a pump which pulls in air at a constant rate. So it gets rid of those things. Regarding the second question, unless you put it somewhere close to your nostril, it's going to be very uncomfortable for people to use it. The next best thing is to actually be able to measure what is the personal exposure on the person as close as possible to where the breathing takes place. We have come a long way in that, because previously the methods that people used was look at your time activity charts and seeing what were you doing at a certain time, and then looking at stationary monitors, and then coming up with some kind of estimation, going down by the square of the distance or something of that sort, to actually estimate for a given postcode or a given location what is the exposure likely to be. And then lots of studies, especially retrospective studies, was based on that. So if you want to do prospective studies, unless you come with a device which is so small that you can put it somewhere close to your nostril where you inhale, this is the next best thing that I know of in terms of these studies. Measure it where it really matters on the person, because you are measuring what the effect on the person is, right? What's the physiological effect on the person? The next best thing is to really measure these things on the person.
And how frequently do we need to have calibrated these kind of devices?
We calibrate it before the study and after the study. And if the study is a long study, then we calibrate in different seasons. Yes, because the water vapor, for instance, you know that has an effect, so we need to correct for that. Yes. When the humidity goes up. Yes.
I mean, we were just in the beginning, we were also looking at the ozone and nitrogen titration.
Yes.
Are you still having some work related to that?
No, I'll leave it to the chemist to do that. I'm a computer scientist. Yeah. Others can do that a bit. Yeah. No, I'm not. I'm not looking at that personally, but I'll just look at the literature and see who comes up with a better method to do the titration between the two. Yes.
There are no questions, and would like to thank Arvind for taking his time and give a nice talk and exposes us to the various exposure devices and all. Thank
Good.
you.
Thank you very much. Thank you. Thank you.
On behalf of
Thank you.
us, like to this is token of appreciation. You was very generous.
Thank you very much. Thank you.
Thank you.
Thank you. Thanks.